This is a sort of highlights bit. A lot of this information is in the annual report. So if you need a bit more detail about it, it's there. But I'll talk about how we've made a difference in a range of different areas. Am I blocking the view for people? Quite sure how to make it. I'll step off the stage for a moment, and then probably people can still hear me. Is that better for seeing? Cool. Okay, so the report emphasises about how our work has raised issues and has led to improvements in services as a result of feedback from patients, views of patients, research we've done with patients and communities, and so on. This stuff comes into us by signposts, and it comes in through research, and it's our role really to encourage health and social care providers to make improvements in relation to what we're hearing. In terms of the scale of our remit, it's obviously very large, and we have to determine what our focus is, where things need to be looked at in more detail. And in our strategic document that was set last time by board, the emphasis was on being more strategic, about focusing on evidence and outcomes, on reaching more seldom heard groups and raising revenue. And Alan, in his presentation, talked about the importance of revenue generation in terms of our model. I think in terms of reaching more seldom heard people, not seldom heard voices, we've done a lot of work around diverse communities, getting to people whose voices may not normally have been heard, and we've built on that work over the last year. But we've also, I think, got to other voices that may not be commonly heard. Voices of people who use drugs and alcohol services, people who are users of sexual health services, autistic adults using GP practices, the voices of carers, obviously fundamental to be heard, a whole range of different groups of people whose voices may be less commonly heard. In terms of some of the figures here, which are quite impressive, I think, so over 10,000 people, up to residents, gave their views, talked about their experiences and so on, which enabled us to have the evidence to raise those issues. I think the next thing is a positive. Maybe other people might not think having 200 meetings with health and care providers and commissioners was what we should, was what they would want to do. But I think those meetings have been really important. We've always been encouraged by providers and commissioners to have those meetings and to give those views. So, important opportunity for patient and community perspectives to be heard. Lots of compliments, and you'll have seen some of those flicking through before. Maybe at the end we can put them up again in case you've missed them. But a lot of credit to the team for the work they're doing all the time, and some of those very powerful messages where people have used our signposts and service for example. I think we could, perhaps to mention the last point, in terms of the diversity of the communities that we serve, we have both recruiting to the staff team and recruiting to board, have been successful in broadening the range of diversity in our staff team, in our board team as well. So I think it's important we try and reflect the broader range of Hertfordshire's community, and we've been able to do stuff around. In terms of research and engagement, you're going to have an in-depth presentation later on from Chloe about the work that we've done on the second one of these, on the primary care themes. But these are some of the areas that we've looked at. The first one as well, the cost of living crisis. Fiona's going to say a bit more about that later on as well. I mentioned that some of these areas where we've done work are reaching people who may not have their voices heard normally. Work we've done around drugs and alcohol services. We've done work about encouraging people to get involved with NHS research, why people are involved or why not, what the barriers, and we've done particular group work are looking at what those barriers are and how they can be overcome. So again, research can be more representative of the people who use NHS services. I'll come back to the international recruits in a moment. Public health, gambling harms. So we've just done a piece of work around the impact of gambling addiction, the impact on families, the impact on people who gamble. Some really powerful stuff in that report, and one to look out for. Concerning just about how people, when they're trying to tackle an addiction, are not necessarily supported in the route they're trying to take. Sexual health services, so very practical research work there, finding out how people use services, how they'd like to use them, what was working, what wasn't, and leading to quite a number of improvements that have been put in place in a very practical sort of way. The Heart's Help work, we did mystery shopping work, and thanks to volunteers who were involved with that work, which was finding out about how Heart's Help was working well, but how it could be improved, and a very good response to that piece of work, which we did in terms of the new provider coming in to provide Heart's Help services, knowing where things had perhaps not worked as well as they might have done before, and being able to put those improvements in place. We also, and it's good to see people involved with these initiatives as well, around co-production in the south and west of the county, where we've got to a situation where patients, voluntary sector and NHS partners are working together and looking to do an increasing amount of co-production work to improve services in the west of the county. And the community assembly bringing together voluntary sector, district councils, NHS partners, patients and so on, to look at issues of importance to the population of North and East Hertfordshire, and again, look at opportunities for patient involvement, look at opportunities for improvement. The international recruits one is an interesting piece of work that we've done, which was looking at international staff within NHS organisations, and what were the challenges that we're facing. If there were people who were thinking of leaving, what were the reasons why, and trying to understand how the NHS could be sort of culturally sensitive to the needs of a diverse range of people on their staff. In terms of signposting and gathering information, as you can see, over 500 hours spent on signposting, but it also shows something about the complexity of the cases that we deal with, that the average length of time for dealing with a case is an hour. Sometimes it's a lot more than that, but it shows people are coming to us often with very complex, challenging issues and looking for help to be signposted in the right sort of direction. Some of the stuff that is done by the signposters can be quite tough, because the cases that we deal with can be where people are really struggling and need support. So it's great the work that the team do around that. Perhaps unsurprisingly, some of the issues that came, the challenges that people are facing, getting support with their GP surgery, getting appointments and so on. Stuff around mental health services, the long waiting list, whether the right sort of support was available. And hopefully that what was in the King's speech yesterday is an indication that parity of esteem for mental health services is something to be moved towards, that sort of stuff. Potential delays to treatment, including surgery, and a lot of people have faced this, and a lot of people are obviously concerned, raising issues, and they're being forgotten, how they're being supported as they wait. And perhaps again, unsurprisingly, the challenge of accessing NHS dentistry remains with us, even for people who have urgent needs of treatment. So I guess sort of communication obviously is central to that as well. Obviously, the organisation is externally focused, and we are about hearing people's voices, going out and doing stuff. But what's fundamental really is about how we as a team run the organisation, how well it's governed, how well the operational systems are in place. So, a lot of stuff goes behind the scenes to make us the organisation that we are. Very strong, effective and governance arrangements there. We've been able to appoint 2 excellent new members of staff, again, predominantly working virtually and broadening the diverse range of people within the team. There's also in the report, there is sort of positive feedback from partners, from the NHS, from social care and so on, people we've worked with and helped, hopefully, and there's some nice stories from patients there as well. So I think that's probably it. I don't know if anybody's got any particular questions.
Yeah, I'm going to break the silence. Nobody's asked a question yet.
Thank you, Richard.
Richard Lake, County Councillor for Edward and Colleagues, former chairman of the council, my colleague is the current one, and I sit on the County Council's scrutiny committee, and from time to time chair some of the health topic groups. Geoff, I want an honest, warts and all comment from you about whether you consider the county council's health scrutiny processes to be useful to Healthwatch, because certainly you attend assiduously, for which many thanks. But really, it's a wonderful opportunity to discover whether or not you think that those processes are useful in terms of determining the way in which public health is delivered and national delivered.
Thank you, Richard. I'll say a little bit, and then perhaps Neil might want to come in as well, as he's more directly involved, I think, with health scrutiny at the moment. So I think for us, that has been a really important relationship. I think we've always felt very much listened to by the Health Scrutiny Committee and the Overview and Scrutiny Committee as well. And when we've taken issues there, they've often chimed with issues that people are hearing from their constituents. I think it's sort of complementary as well in terms of how the work we do holding the system account is complemented by the work you do holding the NHS and care to account as well. And I think what's been good has been able to take our research reports and so on and present those to you, raising awareness of some of the challenges that people face. So I think it's worked really effectively, and that relationship has been an important one, I think, for our profile and also linking in partnership terms. Did you want to add anything, Neil, from your experience?
Well, the only things I would add is I think some of the most important opportunities for us to really get stuck into scrutiny work come not just in the regular meetings, but the sort of the deep dives. So a really good example recently was the pretty much a day looking at prevention, because one of the things we often find, as I think Geoff's presentation showed, is that there are lots of points of connection. We'll hear more about this from Chloe later, in different pieces of work we do, looking at different services in different communities. And some of those scrutiny conversations are a really good place for us to be able to say, here's how that all stacks up. And there are decision-making places in the system where we can do that, but being able to do that in that scrutiny environment is really important. So I think that's one of the real benefits we see of the way scrutiny works. And I think also the fact that the structure also has the impact of scrutiny committee, so that people can't sort of sit through one meeting and then go away, take their tin hat off, and feel that that's done. They know that what the health scrutiny committee has done, or the oversight and scrutiny committee has done, will be followed up. And if impact of scrutiny isn't happy, that's going to come, either back to that avenue, or as in the case with, for example, the gambling work that Geoff was talking about. We know gambling is coming back to health scrutiny because it's been back a couple of times in the impact cycle, and they've not been happy with how things are going. So I think we see that as something that's a very active part of the wider scrutiny process across the council, and well worth the time that we've put into trying to support it.
Geoff, can I just come back to
Yeah, we can.
I'm grateful from that, and clearly that was the answer I hoped I'd get. But we are not too proud to learn. We are certainly not too proud to understand that because we do it a particular way, that may not be the only way to do it, and may not be the best way to do it. So always feel free, Healthwatch, always feel free, because I know you're productive and hard. Thank you for everything you've done, but always feel free to come to us, because we will be receptive in terms of listening if you think there are faults or mechanisms that can be improved.
Thank you, Richard.
Kevin Minier, Vice Chair of the Health Hertfordshire and West Essex Patient Engagement Forum, and I'm sure there's other things that we've seen there. I'm interested in the Herts and West Essex integrated care system, in the sense that Healthcare Hertfordshire, but we also have West Essex, and I was interested in those relationships that we have with those and other areas, because we have a lot of people who use services outside area in West Hertfordshire. So just wondered how that's going and the whole concept of integrated care.
So I suppose there's a positive thing generally that it's the sort of commitment to integration is a message that's coming from the new government as it was previously. So I think that's a relief because of the importance of integration. I think how it, I think, you may have the same view, Kevin. There's something about it's a new way of working, in a sense, working Hertfordshire and West Essex. I think it's easier for us because we're we're 2/3 of it. So I think it can be a challenge for Healthwatch Essex covering a number of areas. I think there's a benefit, and certainly our involvement with something like Princess Alexandra, where we have lots of people living in East Hertfordshire using services there. So it's become more integrated in the conversations, and I work with Healthwatch Essex has been closer there. We work with Healthwatch Essex on the research programme and work we do for primary care, for instance. So we work together on that, which benefits hopefully patients across the piece in the same way that the patient engagement forum is the whole patch, isn't it? I think there's an opportunity and a challenge around services that are provided elsewhere. So patients using Addenbrooke's or patients using London hospitals. So I think there's an opportunity because of being part of the Healthwatch network and raising issues there. But it can be also a challenge. We could face interesting conversations if around Mount Vernon, for instance, around how people in different areas might feel about the developments there. So I think we've moved. I think integration is more. If I do a snapshot 2 or 3 years ago, it was individual organisations in meetings talking about their organisations. I think there's much more conversation now in those meetings that's about integration and working together and the patient using different services. So I think that's a positive.
Yeah. I'm Natalie, head of scrutiny, and I wanted to pick up on Richard's point around the gambling harms and what Neil was saying about scrutiny taking place a few years ago around gambling harm strategy. Some really good recommendations from very positively received. Unfortunately, they have not made the progress that they should have done, and so the Health Scrutiny Committee has decided to review that to understand what is inhibiting progress around that. So I was really interested in the work that you were flagging up, and really an encouragement for the audience here in terms of what Geoff was saying. There's a lot of work goes on behind the scenes to try and make sure that the bits of the system are working together and drawing through the findings and the evidence that Healthwatch have gathered, but we can use within scrutiny to ensure that those very vulnerable people who are at the root of that gambling harms are being considered. And it's not just about the strategy, it's about actual real people. So that patient voice that Healthwatch brings forward is hugely instrumental to the quality of the work that I believe we do within our scrutiny function. So really would like to talk to somebody afterwards about the gambling harms and how we can knit it in to September's committee when it's going to be looking into it.
Thank you.
So, can I just pick up slightly on what you were saying just now about the patient forums, etc. I just wondered what your feeling was. We've obviously got the co-production boards and the community assemblies that are working very hard in the south of the area and the northwest side of the area. Has any progress been made in having something similar for the East Herts and West Essex area? Can you see a sort of similar organisation developing there, or is it?
So I think we've done it by health and care partnership areas. So the east and north area covers the sort of the east of Hertfordshire, and the people here today, Claire, for instance, who attends that and has practices. Her practices are in the east of Hertfordshire. So I think there's a complexity of geography with some of it, in terms of the patient flows and how they work in the east of the county. And there's always a feeling, I guess, if people live in Bishop Stortford or something, they're not seen as central as if they live in Welling Garden. But so we're covering that whole patch, and we do that. I think there is something perhaps about how what we do in East Hertfordshire links into what's happening within West Essex. And I think that it's fair to say, Heather's here who may have a different perspective, but some of those patient involvement forums are perhaps less well developed in West Essex than they are in the Hertfordshire bit of the ICB.
I mean, building on that, Geoff, what's really positive, the Connected Communities work, which was coming from CDA, that was about making that bridge between East Herts and West Essex. And Rainbow Services have been doing it very successfully for 20 years. So it's almost like it's there subconsciously, it just hasn't been formalised. And maybe with the HCP work, it can become more formal. But I think that would be really good.
Thank you. Any of that? Oh, sorry, yes.
My name is Diane Desmuley, and I volunteer for Carers in Hearts. But up until a little while ago, well, a couple of years ago, I was on the clinical commissioning for
Yeah.
I almost forgot what it was called. It was only a couple of years ago. I just wanted to refer to page 70 of the report, where you've got a rather appropriately a no holds barred report about helping carers in heard. And so in your wisdom, Geoff, as you're coming to the end of your tremendous period of work here, perhaps you could say what more we can do to help carers. It's not just being heard, obviously, but acted on. I mean, it's pretty damning, isn't it, to say over 30% not registered, and in many cases inadequate support. And I congratulate staff for putting in some blunt words there. So what would you do now if you were campaigning for carers? What should Carers in Hearts be doing next, and what should patient groups be doing to support this report not just being filed?
No, thank you.
Thank you.
Yeah, I mean, I think there's various facets to that. I think in Hertfordshire it's very positive to have Carers in Hearts and the advocacy and support that's provided, and a voice that is heard, in a way that perhaps it is in other places. I think there's something which is a bit of statement of the obvious, but it just we need to keep mentioning carers in every forum that we're in. So Kevin, for instance, never misses an opportunity to mention the carer's perspective when something's being discussed. And I think that's what it can happen sometimes where I'm in a meeting where the patient perspective is missed, that it's about pathways and about changes. I think that can be even more the case if thinking about the carers. And there was a very positive thing happened where in developing the hospital at home model, it was raised with us through Carers in Hearts that actually had that hospital at home model with all its strengths thought about the added demands that were being placed on carers. And we raised that, and that was then built in as a risk factor in the development of the model. So I think something about, for Healthwatch, hearing those messages and raising them in those forums and getting those things built into systems. I think making sure that carer perspective is heard in those things. And I guess it's also, we have regular meetings with the nursing and quality team at the ICB. And I think those, with something like the report and how the experiences of care has been so different in different practices, it's us raising how is that changing? Are some of the practices that were less good at it improving? And is there anything in sharing the good practice? So I guess that there's a range of sort of practical elements, but I think let's keep making the points really.
Thank you.
That's the use of Hertfordshire, from Cheshire there. Sometimes because you're on the edge of the county, it's very hard to work out which services are for which area, because some are overlapping to Hertfordshire, some are overlapping with that one. Sometimes an emergency service you could be sent on an ambulance to Essex, or you could send to the old days Shakespeare or like Middlesex, one of these is in London, so near Waltham Cross, so you could get sent into a different area that's not always under Hertfordshire. And sometimes when you're trying to access services, you never know which ones are actually covering Hertfordshire, which ones covering Enfield, because we're so close to the border of Essex. And as a user, sometimes it gets very frustrating because the ones you can get to easily, you don't have public transport, is actually in London is easy to get to, public transport, maybe because you don't have a car, than it is to get someone like Stevenage or Letchworth. It's easier to get to someone like Everfield South and Chesham, on public transport, than to come up this way. And as a user, it does seem very frustrating sometimes.
Yeah, I think that's completely right. And we do get signposting calls, don't we, Alice, about this. So it can be the point like you've got, because you're on the edge of the county, you've got different things. Sometimes it can be where a service is provided close to a town or something, but there are no public transport links, so it's very difficult for people to get there. I think it's something we raise, and when services are being developed, being planned, it's really important to know some of that very practical stuff. We had I mean, not go too parochial, but we had a conversation about a meeting in the west of the county, and we were looking for a venue, but because people knew about public transport and where it was easy to get to, we could actually pick a venue that was appropriate. So I think it's something about how the planning of service or the operating of services takes account of the practical issues affecting people in the community. But if you wanted to contact the signposting service about specifics, we could raise those particular points with the providers or the commissioners of those services. That would be helpful.
Thank you.
Hi, I'm Michelle, and I work at Hertfordshire, and the point I would make is that when you're talking about patients and carers, it's not infrequent that those carers are patients themselves. So we know 42% of carers are on pain medication. So they've got twice as many health conditions as everyone else. So it's not kind of us or them. We're all in the same mix of people who've got health challenges.
No, completely. And also we know the impact of being a carer on people's health anyway. No, absolutely. And it's, yeah, we remember that point as well. What are we doing? A bit time for one more question. Okay, sorry.
Yeah, it was sort of on that point as well. And I was at a meeting yesterday where assumed the carers would have no problem reading whatever literature you gave them. The carers come with many conditions. There's a great work done in Bedford a little while ago about carers who themselves are living with autism, which is really good. But I was really generally asking, with all the extra work and the right thing it is for inclusion and diversity, are there any points that anybody can share that that we've noticed that how what they experience differs, so from what other patients are doing? So what other lessons we've learned regarding those, the impact of diversity and what are the solutions?
Yeah, so perhaps and we could hold that, because I think on Chloe's presentation, that's partly about looking at different strands of activity we did around primary care and what some of those shared challenges were, but what some of those individual challenges are. So, yeah.
I'll take that as a segue.
Yeah, I have one more.
Oh, sorry, yeah.
I'm Tom from Charlestown Council, Alex Social Care, and I'm joined funded by the NHS, so remuneration is a key thing for me. Often when you've raised issues to us of an issue where somebody's not got the service that they wanted, we can look into that, and equally if Michelle goes and March raises it, we can look into that particular issue and we'll resolve it. What tends not to happen, in my experience, and we've got to take responsibility for this, is you don't get the systematic change. So often it is people don't understand how to navigate services because it's complicated. You work in the system, let alone your somebody who's in receipt of care and support. More often not, it's about communication. Somebody says something they don't properly understand, or they don't commit to it, or it's not followed up. Far too often, the NHS is as fragmented as social care. 90% of social care provided by the private voluntary dependent sector, so we commission half of it from a local authority perspective. The other half is privately managed and delivered. It's very, very complicated to make things happen. The NHS is, in my experience, equally fragmented and complicated. The acute hospitals are maybe 20 different ecosystems within that building, and then you've got a variety of health providers in the community. So getting the handovers, making sure that there's a systematic communication information flow is proven to be stubbornly difficult. In your experience, if you were to leave us with this is what needs to change in order to make those kind of issues improve, what would be your guidance or parting gestures for us?
Okay, so I think your point about communication is absolutely right, and I think sometimes we slip into professionalism, or we slip into jargon, or if you're talking about pathways, it's no longer a pathway in the road, is it? If there's we're into terror. It's all it's language of the system sometimes, which isn't necessarily meaningful to people. So I think the more it's actually understood by patients, by carers and stuff, the better it is. I think a lot of the calls that we get around through signposting are about those communication issues. People not understanding how bits of the system fit together. I think there's the communication, something about how people can understand that. Why should they know that something is social care or a community service or whatever? So, and they don't really care, they just want the service. I think there's something which you've always done, Tom, and the more colleagues that do it, the better, which is in those meetings where health and social care are coming together, that you're raising the issues of the people who are affected by those services. And I guess there's partly something about, I talked about parity and esteem in terms of mental health versus physical health and so on. But I think there's something about parity and esteem around voluntary sector, around social care and around the NHS. And I think that would be important in terms of the ownership is everyone. And it's all about that individual rather than it's about whoever is the provider and what the services that they provide. Does that answer it?
But it's complicated.
It's complicated.
It's easy with
Oh, no, exactly. No, completely. But I think it is different. I think those conversations, the meetings you and I are in, Tom, some of those meetings, they are more patient focused. There's more about, it's shifted from where it was 2 or 3 years ago, where we'd be talking about the finances of an individual organisation, not like this.